Hello, attendees. Thank you for attending this presentation. I'm Bill Falone. I'm the president of the Northeast region, and we have a guest, and her name is Dr. Jocelyn Fitzgerald. She's joining us today from Magee Women's Hospital at the University of Pittsburgh. Dr. Fitzgerald is the assistant professor of Obstetrics and Gynecology in the Division of Urogynecology and Reconstructive Pelvic Surgery at the University of Pittsburgh School of Medicine. Before medical school, Dr. Fitzgerald attended the Schreier Honors College at Penn State University and earned dual degrees in neurobiology and women's studies with an emphasis on women's health. Her research is focused on mechanisms of female chronic pelvic and bladder pain, patient-centered outcomes of gynecologic surgery, and predicting how women seek care for pelvic floor disorders with a particular interest in the role of social media in women's health. With that, Dr. Fitzgerald will be presenting urinary incontinence and genitourinary syndrome of menopause. Thank you, Dr. Fitzgerald.
Thank you so much for having me and for that very kind introduction. I'm excited to be here today and to hopefully share some information on these critical conditions. Briefly, these are some of my learning objectives. We're going to define what we mean by urinary incontinence and genitourinary syndrome of menopause. For the rest of the presentation, I likely will refer to genitourinary syndrome of menopause as GSM. We'll go over the epidemiology of these conditions, some classifications and differential diagnoses, a basic office evaluation, some anatomy, overview of micturition and the voiding reflex. Then we'll go into some subsets of incontinence, stress incontinence, urge incontinence, and of course, GSM in a summary. So by definition, urinary incontinence is an involuntary leakage of urine. I'm not sure why anyone would voluntarily leak urine other than going to the bathroom normally. But that is the definition. It's involuntary and bothersome to the patient. Urinary incontinence is very common, but I would never say it's normal. I think that a lot of patients have normalized incontinence as part and parcel of aging, but I do not consider it to be normal as it is very treatable in many cases. Risk factors for incontinence include parity, increasing number of deliveries, including vaginal and C-section, although vaginal deliveries do increase the risk of incontinence, and that's what I mean by mode of delivery. And operative delivery is an even more increased risk, particularly for stress incontinence, so vacuum, forceps. Obesity, neurologic disease, family history of incontinence, race and smoking status also have various risk factors for stress versus urge incontinence. Actually, 25% of young women will experience involuntary urinary leakage, and the number continues to rise as women age. So 50% of middle-aged or postmenopausal women will experience urinary incontinence, and 75% of older women, defined as 65 and above. There are some very large costs associated with incontinence. This is almost $20 billion a year in direct cost problem that we face, and 6% of all nursing home admissions are related to incontinence. Families unable to manage the toileting of their older family members. And I have herein all read that patients are very embarrassed by this. They will not tell you that they're incontinent, particularly in a primary care setting or in a gynecologist's office. So this is something we need to screen for, and we must ask patients if they're experiencing involuntary loss of urine. So to classify and kind of go through the differential diagnosis for why a patient might be incontinent, over here on the left are the genitourinary reasons, and some of them are the most obvious ones we think of: infectious reasons like urinary tract infections or vaginitis. Patients also might have what we break into filling and storage diseases. So some patients are unable to maintain urine as the bladder fills, and then other patients are unable to comfortably hold urine in a quiescent state. So stress urinary incontinence is when the patient has leakage with coughing, laughing, sneezing. We call them stress maneuvers, exercise. I have had a patient one time actually get upset with me because I told her that she had stress incontinence, and she said, "Why do all my doctors keep telling me that I'm stressed?" And that's not what it means in this situation. It means that you're putting stress on the pelvic floor with a Valsalva maneuver. Urgency incontinence is when you actually have bladder muscle, which is called the detrusor muscle, overactivity. And that can either be idiopathic, neurogenic, or related to various other systemic diseases like diabetes. And mixed incontinence is a combination of the two, stress incontinence and urge together. Many patients have that phenomenon, and so that requires a tailored approach to treat. And then finally, overflow incontinence, which is much more rare than stress and urge, but there are some patients who can't, they don't empty well. And so when their bladder gets very full, the intravesicular pressure simply overcomes the pressure of the sphincter. The audience I'm talking to now, we do have a phenomenon that we talk about a lot in urogynecology. We'll call it nurse bladder or teacher bladder. These, of course, are individuals in a profession where they hold their urine all day for years and years, and they can wind up at risk for overflow incontinence. Other genitourinary causes of incontinence include a bladder fistula, so either a fistula from the bladder into the vagina, so a vesicovaginal fistula, but also iatrogenic causes of fistula can occur via urologic or gynecologic surgery, where a patient could have a ureteral injury and a fistula, or a urethral injury and a fistula. There are rare known causes of congenital incontinence from an ectopic ureter or epispadias, which I'm not going to focus on today. Other non-genitourinary reasons for incontinence could be functional incontinence. These are patients who, I have many of them in my office, simply do not have the mobility to make it to the toilet in time. Of course, there's a component typically of urgency or overactivity to this, but if a patient has a walker or some other mobility impairment, they simply cannot get to the toilet in time. Neurologic causes, stroke, dementia, all can contribute to incontinence. And then, of course, there are psychologic reasons, especially that require certain psychotropic medications that can contribute to incontinence. Other things could include environmental factors that make it challenging to get to the toilet. I mentioned some pharmacologic things. Then metabolic, the biggest one being diabetes, but there are other metabolic conditions in the cortisol pathway, or patients with SIADH, diabetes insipidus, that can lead to a lot of urinary incontinence. And I highlighted in red that a lot of these diagnoses can be made simply with a history and physical exam, and not any more advanced testing beyond that. So let's just say in your office evaluation, you ask the patient, "I'm here because I leak on myself, or I wet myself. I can't get to the toilet in time." In addition to basic medical, surgical, and social history, some things that you want to ask about in order to decide what the underlying mechanism of their incontinence is do they leak with coughing, laughing, sneezing? Or do they more leak with urge? Do they leak with both? Do they leak when they go from sitting to standing? Which is worse? What is the biggest trigger for the leakage? How much do you leak? How many pads do you go through? Do you ever leak with no realization? You leak without sensory awareness. Do you leak with intercourse? Do you leak from the vagina? Do you leak while you sleep? Do you leak with a pessary is in, if the patient has vaginal prolapse? Or do you leak after you think you've completed urination? The basic office evaluation also involves starting at the basics. So a bedside urine dip. We all have done those. You're looking for the big three: leukocytes, nitrites, and blood. Honestly, I'm more interested in nitrites and blood. If we're being very honest, leukocytes often come from any contaminated clean catch sample because vaginal discharge has a lot of leukocytes in it. But nitrates and blood are really more specific for a UTI. And so if you feel as though the urine dip is screening the patient towards possibly having a urinary tract infection, of course, sending a urinalysis and urine culture is warranted. I always get a post-void residual on almost all of my patients with urinary symptoms. You can do a scan or a cath. In general, you want a post-void residual to be less than 150. There are some clinical scenarios where more than that is not problematic, and we can tolerate post-void residuals up to 300 or 400 cc's in certain circumstances. That actually isn't as dangerous as people think, unless the patient is getting repeatedly infected. As long as their kidneys are doing well, they're not getting hydronephrosis. Post-void residuals are something that can be flexible depending on the clinical scenario. You also want to do a good neurologic exam, basic cranial nerves, really just looking at the patient. Or is their facial symmetry, their upper and lower extremity strength and sensation symmetric? Do they have any signs of spinal deformities or spinal disease? Those would all be reasons that somebody might not be neurologically intact, and that certainly can contribute to their continence. Things you want to look for on a pelvic exam: you want to look for any skin changes from urine contact or diaper rash, sensation. If it's really sort of not clear, you can do a Q-tip test to verify a patient's sacral nerve reflexes by touching softly on their inner thighs. You can get a motor function evaluation done fairly quickly by eliciting what's called a bulbocavernosus reflex or an anal wink. You literally just have to sort of lightly brush against the external labia, and you'll see the perineal muscles contract. And if you see that happening, you know that the patient has intact motor reflexes to their sacral nerves. So neurologically, their voiding function should be intact. You can do what's called a cough stress test. So this is to look and see if a patient has stress incontinence. To do this, you want a patient to have a comfortably full bladder. Around 200 mLs is kind of typical, but more than that would certainly be fine. You want to hold the labia minora back so you can visualize the urethra. Hold something in front of yourself. We've all made this mistake. I often use the unopened speculum packaging that I use for the rest of the pelvic exam to protect myself from a positive cough stress test, so you don't get sprayed with urine and have the patient cough. There's some like sort of more old school evaluation of the urethra. What this is describing on the slide is the AA point, which is the invisible point that's right at the junction of the bladder and the urethra. Does it move when the patient coughs? Like, is the urethra swinging towards the vaginal opening? That's suggestive of a patient with urethral hypermobility. That being said, urethral hypermobility doesn't necessarily predict whether or not a patient will be incontinent, so it's sort of just a data point for your exam. You also want to look for any masses or any bulges that might be suggestive of a urethral diverticulum. This will look like a cyst in the suburethral area, or sort of off to the sides and the periphery of the urethra. Does the patient have a caruncle, which is urethral atrophy, where the inner lining of the urethra actually prolapses out slightly? The mucosa of the urethra bulges beyond the opening of the urethral opening. That happens typically in postmenopausal patients. And then the last thing you want to do is a bimanual exam. And this is where you're feeling for any uterine or adnexal pathology in the fallopian tube or the ovary, really feeling for masses or fibroids, something that might be pressing on the bladder. Evaluating for urethral or bladder tenderness. Gently, I press under the urethra and then put my finger in a little farther and palpate the anterior vaginal wall. That can lead towards more of an infectious cause or a patient that might have painful bladder syndrome. And then you also want to test the patient's pelvic floor muscle strength. You can feel the pelvic floor muscles when you put a finger in the vagina. You go off to the right and the left just inside the opening and ask the patient to either do a Kegel or squeeze as though they were trying to stop the stream of urine or stop passage of gas. And they usually will be able to mobilize those muscles, and you can check to see if they might benefit from pelvic floor therapy, which we're going to talk about in later slides. And then the last thing is you want to look and see when they cough, or you can have them bear down in Valsalva if they have any prolapse. Prolapse and incontinence are two totally different things. They are somewhat related, as they're both pelvic floor disorders that are related to tissue defects, but I can't tell you how many patients come to me and they do not know that incontinence and vaginal prolapse, or quote, your bladder falling, are two different pathologic things, and they're treated in different ways. The last thing I do, especially in elderly women who are giving me a history of constipation, I'll do a rectal exam to check for anal sphincter defects. I'll have check both resting tone and have the patient squeeze. And I'm really feeling for fecal impaction, because fecal impaction is a big reason that makes urinary incontinence much worse, because again, it's a mass effect, and it also puts a lot of stimulus in the sacral reflexes when the rectum is distended, which affects the urinary reflexes as well. I've written here TBD, urodynamics. A lot of people have a question about whether or not patients with incontinence need to have urodynamic testing. And the short answer is most of the time they do not. You can get most of the information that you need from this evaluation: a history, a physical, a urinalysis or urine dip, and a post-void residual. We reserve urodynamics for patients with really more complicated situations, like history of prior pelvic surgery for incontinence, or some sort of really complex neurologic voiding dysfunction. So this is just some basic bladder anatomy. I referred to some of this a little bit, but just to review, the bladder wall is made up of 4 separate layers that all have fairly sophisticated jobs. So the innermost bladder wall is the mucosal lining, or the urothelial lining. The urothelium is where lots of the sensory nerves of the bladder are located, particularly in the trigone, which I'll draw your attention to in the cross-section of the bladder on the left. The trigone is that white triangle that outlines between the ureteral orifices, where the urine drains into the bladder from the kidneys, and the urethral opening. And that's where the majority of the afferent nerve supply, or the sensory nerve supply to the bladder, lives. And we tend to see a lot of pathology pop up there, a lot of erythema and inflammation in patients that have had recurrent urinary tract infections. They can get a biofilm there, and that is all lined with urothelium, which has a lot of sensory properties to it, even though it is considered to be a mucosal lining. And then there's a submucosal lining, a muscular lining of the detrusor muscle, which is outlined there. The detrusor muscle is the main bladder muscle. It's smooth muscle, and its job, when it's functioning properly, is to relax as the bladder fills, and when the bladder reaches capacity, it starts to contract, and that is what our brains interpret as a strong urge to void. And that it gets stronger and stronger the more and more the bladder fills, until we sit on the toilet, we give our brain and our pelvic floor permission to void. The urogenital sphincter relaxes, and the detrusor muscle completely contracts. And urgency incontinence and overactive bladder come about when that detrusor muscle, or that reflex, is not well coordinated. This is a little bit of urethral anatomy, and this is a little bit complex, and not all of it is really necessary to go through for the purposes of this talk, but this is sort of just to illustrate the fact that the urethral anatomy when it comes to sphincter function and holding urine in the bladder is not just dependent on one mechanism. There are several mechanisms that are happening at once. And in order to become incontinent, you have to lose usually more than one of them. So there's compressor urethral muscles, there's some ligamentous sort of hammocks that support the urethra. And then, of course, the pelvic floor and the vagina also confer extra support under the urethra. So in patients that have stress incontinence, they've had pelvic floor damage from childbirth, perhaps loss of some ligamentous support, or some other damage to their compressor urethra, maybe some nerve damage that has contributed as well. So briefly, I'm going to do a little overview of micturition. This is how we control urination, and this chart is divided into two sides. So on the left, we have storage, and the mnemonic we often use is storage goes with sympathetic. So this is when you're running from a tiger in the woods. Your bladder is the last thing you need to be thinking about. So this is really where your detrusor relaxes and your sphincter contracts. You're holding your urine at this point. And I will have a little asterisk here to show that we all know that even though a lot of this is unconscious, we do have some conscious control, of course, over our bladders. This is our external sphincter is under somatic control, which means that we can control it. That's under the control of our pudendal nerve, and we can, squeeze, we can hold urine in. On the other side is peeing, which is parasympathetic. This is the resting. We're safe now. We're not running from the tiger anymore. We can sit on the toilet and relax. Our sphincter can relax and our detrusor can contract. And we also have some control over this as well, that we allow our external sphincter to relax, our pelvic floor to relax when we sit on the toilet. And I also want to draw your attention back up to the left, where next to detrusor relaxation, I have a B, which stands for beta receptors. And I'm going to talk a little bit about how we manipulate beta receptors when we treat a sympathetic storage disorder. And over on the right, it says detrusor contraction with an M next to it. M stands for muscarinic receptors. And I'm going to talk about how we manipulate those receptors as well when we're treating urgency incontinence. This is just a little bit of demonstrating where those receptors are. So if you look at the top of the dome of the bladder, the upper part on the right there, you'll see beta receptors are throughout the detrusor muscle, as well as muscarinic receptors, and they work in opposite ways. Muscarinic receptors are related to micturition response when the detrusor is contracting, and the beta receptors are what keep the detrusor relaxed as it fills when we are not yet ready to void. And on the left over here, I just wanted to demonstrate how complex the system really is on both the local level of the spinal cord, where you're having reflexes down in the sacrum between S2 and S4, and then we have multiple neural pathways that go up into the spinal cord and up into the brain. So let's go back to stress urinary incontinence. So this is when a patient has involuntary leakage with abdominal effort, exertion, sneezing, coughing, and it's the most common type of urinary incontinence. 50 to 70% of women with urinary incontinence have the stress type. They often will leak with a cough stress test in the office, so it's easy to diagnose. It's associated with urethral hypermobility, which I mentioned earlier, but this doesn't. I find patients all the time with urethral hypermobility on exam who don't have stress incontinence. So in that regard, it's not a great test. In patients who have intrinsic sphincter deficiency, these are patients whose sphincters are simply not working well. The urethra isn't hypermobile. It's still anatomically fixed in the location that it should be. But these patients at rest, they have an open bladder neck and very low leak point pressure. And the numbers that I have here are numbers that we use in urodynamics to define the leak point pressures, but clinically we don't actually have to use these. But this is how the American Urologic Association has defined intrinsic sphincter deficiency in patients who they barely have to do anything and urine just comes right out. They tend to have very low leak point pressures because their sphincter is just not coapting correctly. Urgency incontinence is a patient that has a strong sense of urge. They feel as though they absolutely must go to the bathroom right now. They feel their bladder squeeze and contract, and then they leak before they can get to the bathroom. They can't control it. Patients with overactive bladder have the same syndromes of urgency, but they don't always have leakage, but they do have nocturia. They wake up at night to go more than once, and they have frequency during the day. So I include this definition of detrusor overactivity. Technically, we define it by urodynamic studies, because the only way you truly know that the detrusor is what's overactive is to see it on a urodynamic test. However, we do use detrusor overactivity kind of interchangeably with urge incontinence when we're talking about patients or clinically diagnosing this condition. For anyone who ever wondered or has never seen urodynamics, the way urodynamics works is that we put a very small catheter in the bladder and then a very small catheter either in the vagina or in the rectum. And the catheter in the vagina or the rectum is a pressure sensor that serves as a surrogate for intra-abdominal pressure. And we ask patients to do a variety of maneuvers. And basically, we're trying to figure out if the bladder muscle is squeezing independently of a rise in the abdominal pressure. So if we see the abdominal pressure or the rectal pressure staying flat, and then the bladder pressure is going up, that tells us that this is probably not related to pressure on the bladder, meaning the patient's not leaking when the bladder pressure goes up. The patient is leaking because their detrusor muscle is contracting against the permission that the patient has given. So urodynamics, I mentioned them a couple of times. This is just reasons to get them. I get them only if the patient's story is very confusing and they have a very unclear diagnosis after their office evaluation. Maybe they're telling me that they're losing urine with stress, but their bladder is also not emptying well. Maybe they have a history of a treatment failure. They've tried a medication for what it sounds like is urge, but they haven't gotten any better whatsoever. Occasionally, we do it for preoperative planning in a patient with prolapse. Prolapse can actually mask incontinence because when the anterior wall of the vagina sags down, it can sort of kink the urethra and protect patients from leakage. We also could do it in overactive bladder that's refractory to conservative treatment, that's similar to treatment failure above, or a patient who's previously had a sling and they still have urgency or still have urinary incontinence, and we can't really figure out why the sling didn't help. And so these are the parts of urodynamics. They consist of a uroflow, which is literally just the patient voiding into a funnel that has a flow meter on it and a volume sensor, and it kind of tell us how easily the patient is able to void and how completely they void. Filling cystometry is when we fill the bladder and then we ask patients at what volumes they're feeling the pressure and urge to void. It also can tell us at what pressure and volume patients leak at. And then pressure flow studies tell us some information. These are done with the sensors in place. They give us some more information about how much sort of strength the bladder muscle is able to mount in order to empty the bladder. And then we can do some other fancy things like EMGs and urethral pressure profiles, but they don't typically change our management very much. I want to talk a little bit about cystoscopy. There are not a ton of indications for cystoscopy for garden variety urge and stress incontinence. They are not typically indicated, but in a patient that has hematuria, pyuria, their symptoms are not resolving. Their symptoms are very irritative, and they sort of just don't sound quite right. I had a patient who I diagnosed bladder cancer in a couple of weeks ago who had only had a telemedicine visit, but something about like her sort of new urgency and her sort of irritative voiding and pain just didn't really sound like classic urge incontinence, and she ended up having bladder cancer. So it was a good thing that we did a cysto in that case. But these are patients, they have pain, UTIs that keep coming back, concern for a fistula, concern for a mass. They have a history of a vaginal or urethral mesh, history of a foreign body, maybe a stent or for a stone, that kind of thing. Those are patients where a cysto is really indicated. And so going back to management, we'll talk about how you manage stress incontinence. So these are patients, again, who leak with cough, laugh, sneeze, and we have a whole slew of treatments that go from least invasive to most invasive, and I'll go through them. Behavioral modifications, those are patients, for example, who tell me that they only leak with stress maneuvers when their bladder is really full. So if I find out that somebody is only going to the bathroom once every 4 or 5 hours, I'm going to tell them to go every 2 to 3 hours to keep their bladder a little bit more empty. These are also patients that, depending on what kind of exercise they like to do, if there's only certain things that make them leak, maybe we can work on that, or we can send them to physical therapy to try to get their stress incontinence to decrease with some pelvic floor strengthening. Medical, there are technically medications. There's one medication that is FDA approved for stress urinary incontinence, but nobody uses it. It really doesn't work. We do have incontinence pessaries. These are pessaries that have knobs on the end of them. It's a ring that goes into the vagina and puts some upward pressure on the urethra. We have urethral bulking, which is when I tell my patients it's kind of like getting fillers for your wrinkles, but instead we're putting it in the urethra to plump it up. This helps the urethra to, again, the word we use is coapt, to have it come together and close more completely when the pressure in the abdomen or in the bladder goes up. And then we have slings, which I think a lot of people have heard of. Slings are inserts that go under the urethra through a vaginal incision. They can either be synthetic and made out of lightweight polypropylene mesh, or they can be made of the patient's own tissue, which is called a fascial sling. The fascia is often harvested from the rectus abdominis or the fascia lata on the leg. More often it is an abdominal approach. And a birch, which is a little bit of a more old-fashioned surgery now, but a birch colposuspension is a surgery that's done usually robotically or laparoscopically these days, where the vagina is sort of pulled up around the bladder neck from a retropubic approach. So here's some more examples of behavioral management. We want patients to manage their fluid intake. We want them to time their voids if they're not going very often. We want them to go to pelvic floor physical therapy. This is first line. There are home pelvic floor trainers that patients, particularly postpartum patients, have a lot of success with. The goal is for patients to be able to consciously contract their pelvic floor with Valsalva to prevent urine loss. And this does take work. It takes at least 4 weeks of physical therapy. Another thing that we really do want to stress to patients, of course, without body shaming them or making them feel as though this is somehow their fault, because it's not. Stress incontinence is very multifactorial, but there's very good research that shows that in an obese patient population, that weight loss is very effective at reducing leakage with coughing, laughing, sneezing. In obese patients, every 1 kilogram lost results in about a 3% decrease in the likelihood of developing urinary incontinence. And we also have another study that shows in an obese population, a modest 10% body mass weight loss, a 10% weight loss can decrease incontinence by 50%. So definitely effective. Other things that we do for stress incontinence that can be helpful, their vaginal estrogen, which I'm going to talk about more in the GSM portion, can be very helpful for stress incontinence because it helps bring sort of new blood flow and turgor to the vaginal tissue, which can contribute to loss of urethral support. And then there are various antidepressant medications that are used for stress incontinence, but we don't use them that much. This is the stress incontinence pessary that I was mentioning. They are ring-shaped. You'll notice most of them don't have support in the middle. Some of them do if the patient has prolapse as well. But if a patient is using a pessary solely for stress incontinence, it's an open ring with a knob, and the knob sits underneath the urethra, so pointing out distally from the patient. This is a nice image of urethral bulking. So this is for patients who, in particular, it works really well if they have that really low pressure at their bladder neck that is pathognomonic for intrinsic sphincter deficiency. We will do this in patients either before or after sling. There's no perfect way to do it. But if a patient has persistent stress incontinence after a sling, or cannot undergo additional surgery or decline surgery, or doesn't want to undergo anesthesia, it can be done in the office. And you can see here that we put a small urethroscope, or it can be done with a cystoscope, into the urethra, and then using a syringe full of the bulking material, we put these little cushions in the periurethral location. The one that's kind of the most popular nowadays is Bulkamid, which is a water-based polyacrylamide hydrogel. This is the one I do the most often, mostly because it has a proprietary urethroscope that is more comfortable for patients and makes the procedure very easy. But there are other brands, Coaptite and Macroplastique, or two other brands that are used and have been for years, and there aren't huge differences in efficacy between these. These work about 65% of the time. And then probably what we are most used to using is a midurethral sling. This is for patients who really have refractory stress incontinence. Physical therapy has not helped. Injections have not helped. Pessaries have not helped. And the sling that is considered to be the superior sling in the in randomized control trials and also in systematic reviews is a retropubic approach to the midurethral sling. Some people know this as a TVT. TVT is a brand, but that is the most common sling that we do nowadays. And you can see here the dissection of a pubovaginal or a bladder neck sling. This is the rectus fascial harvest, and that is placed through the vagina. Here are just some schematics of how a retropubic sling is placed. We make a small 1 to 2 centimeter incision in the suburethra through the vaginal epithelium and make suburethral tunnels that go off to the sides of the urethra and back through the retropubic space. And then the sling is placed retropubically in front of the bladder, and then placed tension-free under the urethra, which is a very important point. Slings are not meant to have tension on the urethra. They're simply there to act as a sort of backstop support. Here are some more examples of how a transobturator sling is placed. Transobturator slings are placed more through the groin, under the ischiopubic ramus. They have an increased risk of groin pain for obvious reasons. And in terms of the longevity of their efficacy, have been shown over time to be less effective than a retropubic sling. In a patient with failed stress incontinence management, we will move towards a fascial sling, but these are overall very uncommon these days among urogynecologists because they are invasive and they do have fairly high rates of urinary retention. The birch urethropexy is also still very much done in patients who do not want mesh or having a robotic prolapse repair at the same time. This is done in the perivaginal space with permanent suture lateral to the urethra, and the ligament that the vagina is attached to is the Cooper's ligament in the retropubic space. And it has been shown to be successful at 1 year, but we know that these have far inferior efficacy to the midurethral sling, which we now have 20-year data on. So this is how the birch urethropexy is done. So urge incontinence, I know that we're running a little low on time, but urge incontinence is something that people are very interested in knowing how we manage, and I'm going to go through the behavioral, medical, and interventional steps for this as well. Probably one of the most important things that can be done for a patient who leaks with urge is to review what they consume in a day, particularly with regards to their drinking habits. How much volume are they drinking? Are they drinking bladder irritants? Are they drinking coffee all day? Are they drinking soda or diet soda all day? Are they drinking a lot of caffeine? Are they drinking a lot of alcohol? Are they drinking a lot of citrus fruit? These are all things that can be extremely irritating to the bladder and cause bladder spasms. And so I really encourage patients to cut back on these things. There are supplements you can take before a particularly acidic food like coffee or citrus fruit called pre-leaf. But in general, I try to get patients to cut down on these as much as possible. I try to get them to do avoiding diary if they can. This helps know how big their leaks are, what their triggers might be. And then I really encourage them through coaching, and I have some handouts on this that are easily available on the American Urogynecologic Society website on how to do timed voiding and urge suppression techniques so that patients, if they're triggered, for example, by pulling their car into their driveway or putting their keys in their front door lock, that they can learn some relaxation techniques and some techniques for activating their pelvic floor that will allow them to get to the toilet in time. And pelvic floor physical therapy can be extremely helpful with this sort of bladder retraining, bladder reconditioning. I promised that we would come back to those muscarinic and beta receptors. And these are important because the medications that we use for urge urinary incontinence management require or are dependent on manipulating that system. So you can see on the left here, these are medications that have been around for decades. Patients and providers alike are very familiar with them. The anticholinergic medications like oxybutynin, Detrol, Vesicare, Sanctura. The sort of problem with these medications nowadays is even though they're very inexpensive, they have been closely associated with dementia. And so they are not recommended in women over 65. Unfortunately, a lot of insurance companies will not allow a patient to move to the right side of this slide into the beta-3 agonist category. These are the pro-storage medications until they have tried an anticholinergic, which is much cheaper and has many more side effects. But we as urogynecologists really prefer the beta-3 agonists. There are two of them on the market, mirabegron and Gemtesa. Mirabegron and Vibegron. Mirabegron is contraindicated in a patient with uncontrolled hypertension. Hypertension is really its best known side effect, that in a small number of patients, it can raise blood pressure by around 10 millimeters of mercury systolically. It's overall a minor side effect, but Vibegron, which is a newer medication, does not have those hypertensive side effects. So it would be our preferred medication probably overall, but it's also the most expensive. So we end up playing a lot of back and forth with insurance companies. Another intervention that patients are usually very interested in hearing more about is posterior tibial nerve stimulation, which we often sometimes call kind of like acupuncture for the bladder. The posterior tibial nerve actually synapses in the spinal cord at the same level as the bladder reflexes. So we can actually modulate the neural function of the bladder through the tibial nerve. This does require some commitment from the patients. They have to come weekly for 12 weeks. And so they have to be very compliant patient and also be able to come to the office frequently. So I don't do this a whole lot. A lot of my patients come from far away. This is pretty tedious for them, but especially in research settings and in a motivated patient, this can be very effective. So now I'd like to briefly talk about one of the things I said this talk was going to be about, which is genitourinary syndrome menopause. And I don't think any incontinence treatment plan should go without attention being paid to this condition. This is not just vaginal dryness. This is a collection of symptoms and signs that are caused by having low estrogen, and they affect the labia, majora, and minora. They cause atrophy, the clitoral anatomy, the vulvar vestibule and introitus, which is the immediate vaginal opening, the vagina itself, which is the internal portion of the female reproductive tract, the urethra, and the bladder in menopausal patients. And it It is replaced vulvovaginal atrophy, and these are the symptoms that it causes: dryness, burning, urethral pain, vaginal pain, irritation, recurrent UTIs. This is the number one cause of recurrent urinary tract infections in older women: urgency, dysuria, dyspareunia, and then, of course, incontinence. So the vaginal epithelium and vulvar and urethral tissues are very estrogen sensitive. And the mechanism of this that a lot of people don't realize is that the vaginal epithelium, in response to estrogen, produces glycogen. And then glycogen is uptaken by lactobacillus to create lactic acid byproducts. That lowers the vaginal pH, and a low vaginal pH is optimal for lactobacillus, obviously, but very suboptimal for gram-negative and anaerobic pathogens that cause UTIs. So this is how you use the vaginal microbiome to protect the bladder from infection. So well-estronized tissue, in addition to producing glycogen, it also becomes much more cushion-like. It's pinker, it's moister, and that pink moist tissue protects sensitive urethral tissues. Some other low estrogen states that patients can have that are not just menopausal: a lot of patients are on hormonal suppression, often continuous low-dose birth control pills in patients with endometriosis or pelvic pain. Breastfeeding patients have very low estrogen. Infertility treatments, breast cancer treatments, all cause a relative decrease in bioavailable estrogen that creates symptoms very similar to GSM. So don't just think this is in patients who are postmenopausal. And there's a lot of ongoing research in the role of the vaginal microbiome on bladder health in the premenopausal patient. So this is just a schematic to show how dramatically the vaginal epithelium can change. On the left is the vaginal epithelial layers in menopause. You can see how thin that basal layer has become. And on the right, how thick and sort of lush and how much more protection the urothelial and suburethral tissues will have when the vaginal epithelium is well estrogenized. So how do we treat this? It's really very easy. I'm a fan of using generic estrates cream, vaginal estrogen, 0.01% topically. I use a 0.5 gram nightly or 1 gram twice weekly. There's really no consensus on this, but both are safe doses. You also could use S-strings or Vagifem tabs. Whatever is most affordable to the patient and what they're most likely to use is the right thing. Some providers consider a vaginal androgen, like a DHEA suppository or testosterone. The data are mixed, but for some patients that also have some vestibular pain, using an androgen may be more efficacious than vaginal estrogen, but that's a little bit outside the scope of this talk. Ospemifene is a SERM that's FDA approved for dyspareunia due to postmenopausal vaginal atrophy. And then, of course, paraben-free vaginal moisturizers with an acidic pH are recommended by the WHO as treatments for GSM. I tell my patients that I highly recommend coconut oil or silicone-based lubricants if they're experiencing sexual pain from their vaginal dryness. So that kind of goes into the overall bladder health basket, but I do want to come back briefly to some of the third-line treatments for urge urinary incontinence before I conclude. So this is a schematic of sacral neuromodulation. Sacral neuromodulation is when we actually put a wire in the S3 sacral foramina and connect it to a stimulation device. And this actually is FDA approved for urge incontinence and overflow, as long as it's not obstructed. So in that way, it's confusing. How can neuromodulation help both underactive and overactive bladders? The mechanism is not very well understood, but it is thought that it modulates and sort of reprograms the reflexes in the sacrum. It can be either done all at the same time, the battery and the lead, or it can be staged. And of course, it comes with typical surgical risks of pain, lead migration, infection of the implants. This actually, I should have updated this slide. You can get future MRIs. The MRI compatibility is a very recent thing that has come out. Both companies that make these devices now have MRI compatible implants, and this can be expensive. So there are some issues with insurance coverage sometimes. My favorite third line treatment for urge urinary incontinence is intravesical Botox. So we actually cystoscopically place Botox into the bladder muscle. You can do up to 300 units. The starting dose is 100. And this needs to be repeated every 3 to 6 months. I do have some lucky patients that get up to 9 to 12 months of relief from their incontinence from Botox. This can be done in the office, so patients really like that. It overall has a lot lower risks, in my opinion, than sacral neuromodulation does. It has about a 6% risk of retention in UTIs. And this, above all other treatments that we have, including sacral neuromodulation and medications, is the most likely to have a patient go from being wet to dry. So we love Botox. And that is pretty much everything I wanted to talk about today. Thank you so much for your attention. I look forward to answering your questions.
Wow. Thank you very much. That was interesting. I do have a couple of questions. With as many, your very last slide with the Botox injections, there are an awful lot of spots that require the injection. How long does a single treatment like that take?
That's a great question. And so this picture, there are many practitioners that still do about 20 injections into the bladder, which is about a half a cc per injection. That is not what I do. I do more like 8 to 10. There have been some more updated studies that show they're equally efficacious, or at very least non-inferior. And that only takes about a minute to do. I do it pretty fast. So, and the patients get pre-treated with intravesical lidocaine. So a lot of them really have almost no discomfort, but it only does take 1 or 2 minutes. It takes longer to set up the cystoscope and to get the Botox mixed than it does to do the procedure.
In a case, and I do have other questions, but with the Botox administration, are you trying to do it in specific areas, or how much does that matter that it's specifically administered?
That's a great question, and there have been a few studies on that. For years, people were trying to avoid the trigonal region of the bladder because they thought it was maybe too close to the ureteral orifices, or that it would be too uncomfortable for the patients. But it has been shown that doing injections in the dome of the bladder and in the trigone, where the sensory nerves are, is more efficacious than doing the dome alone. So I tend to do about 8 injections in the dome and then 2 in the trigone. So 10 total but depends on the patient's, the size of their bladder or their anatomy.
Is the effect immediate?
It takes about 5 to 7 days for Botox to reach its full effectiveness.
Okay, great. You mentioned earlier in your talk about obesity being an issue that can contribute to incontinence. Tell me something. Does obesity reduce the effectiveness of corrective surgery, such as slings?
Yes, that is a great question. And there have been many studies done recently trying to answer that question. And overall, the answer is no, actually. And I think that's something a lot of providers clinically suspect is the case. It makes sense that obesity would make a sling less effective, but so far that hasn't been shown in the studies. Obese patients have very good responses to slings. They do have some other risk factors typically for sling complications, like a mesh exposure, especially if they're diabetic. But overall, they're actually still very efficacious.
Oh, super. Okay. And finally, with your discussion of hormone therapy, is the hormone therapy ever done prophylactically, or it really needs to be, a treatment?
I love that question. I don't know that anyone fully knows the answer to it, but ultra low dose estrogen topical cream is so safe. I should have mentioned in my talk that it is safe to use in all breast cancer survivors. It is safe to use in women that have a history of blood clots. And so I frequently will see these changes starting in my patients who are perimenopausal, in their early 50s. And I'll recommend that they start it, before they were doing more of a damage control situation in their 60s, 70s, and 80s. So from what we know, there's no harm whatsoever in sort of starting it prophylactically.
Interesting. That's terrific. Well, Dr. Fitzgerald, I certainly appreciate what you shared with us, and interesting stuff that I've not heard before, and appreciate you being out there for us as well.
Yes, thank you very much for having me. I hope everyone enjoys the rest of the conference.
Thank you very much. One last word to our attendees. Please do not hesitate to take care of your evaluation of this presentation and the rest of the presentations that you'll see. The deadline for our evaluations is December 31st. If you get that in before December 31st, we can give you credit. If it's after December 31st, credit cannot be issued. So please be sure to follow the directions on the attendee hub, and you will have your CEs. Okay. Thank you, Doctor.
Thank you so much. Have a great day. Thanks for your patience.
You too.
Bye.